When we see someone who's newly diagnosed with breast cancer, we're not just thinking about where they are right now, we're thinking about where they're going to get to. When you're seeing someone newly diagnosed, what are you thinking about beyond just their surgical plan, that what's going to be on the other side, what's their follow-up going to look like? What are those thoughts going through your head when you first see someone?
I think there's so many different things when a patient walks in. I think it's so important just to set patient expectations, talk to them about what they want to look and feel like, not when they're cancer-free, when they're cancer-free 5, 10, 15 years down the road. So give them that vision of where they're going to be and what they're going to look like. I think also taking into fact lymphedema prevention, super important. You know, we need to be honest with patients that surgery and radiation can cause complications. So being upfront with patients, spending the time, finding out what they want to look like, and also how to mitigate those complications is one of the biggest things that I do in my clinic. How about you, Anushka?
Yeah, absolutely. I mean, you're right. There are so many different factors, aren't there? And I think with part of what we do, there's a huge empathy in that, in not only getting them through the first surgical phase, but you kind of feel responsible for how they might feel later on down the line. We often put them on medications that make it difficult to lose weight, yet we tell them that losing weight is actually important for risk reduction. And I think that we've got to take away that guilt factor for them. So I feel like we need to really work on supporting people from that side of things. We talk about survivorship, but surviving in that context is actually really, really easier said than done when they're not with us anymore. And a lot of them also really struggle with that safety blanket, they say, of having hospital care. So we let them go off and go, there you go, back to normal. And now they're not normal anymore. We've changed everything about them.
They find their new normal, right?
They find their new norm, and so that's how I kind of twist it as well. Absolutely. Is that what you say to them?
Yeah, I tell them that. And I also think that I talk about survivorship as a living period. So they're not just surviving, they're living cancer-free. And so what can I do to support you in that life journey cancer-free? Yeah. And I think, Anne, I mean, what do you...
No, I mean, I love that so much. And I think that concept of how disruptive getting a cancer diagnosis can be, and thinking about how can we get people, what does that new normal look like? But how can we get them as close to their same normal as before? And so one of the things I often tell people is really get to know your patients. You know, get to ask about what matters to them, what are they afraid of, what do their lives look like, and what are the parts of surgery, potential complications, potential screening, like what are going to be the things that really continue to disrupt their lives? Because we see people, right, who turns out they probably can never again handle having to go in for breast cancer screening. They just, for whether it's family history, whether it's their where they are psychologically, and so those are people. Let's try to support a different option for them so that they're not getting screened. And so trying to figure all that out, it's a lot to figure out at the beginning, but I think it's time that is well spent for us as providers and also for our patients to take that time to let themselves really get educated on all their options so they can get the best choices.
No, I love that. And I feel like it changes too. I feel like when that first talk, it's all about the surgery, do I need chemo, what am I gonna look like, all those things we go through. And then when they really get into that living period, it's like, what has changed in your life? And that's where I find myself taking, everyone says, oh, that first consult, we spend so much time, which we do. But I do feel like in that living period is when I really spend a lot of time with patients. What do you need? How can we help you with hormones and all the above?
Yeah, it's a whole holistic assessment, isn't it?
Yeah.
And I think healthcare professionals, I really feel quite strongly that across the board, they need to be better trained or better versed in how to deal with those holistic discussions, because we're not just surgeons. As you said, you're there for the whole person. Sometimes, okay, we're not responsible for their families, but you do feel that you have an impact. Everything you do to that person has an impact on how they live their lives afterwards. What I find quite fascinating is how few people feel that anyone has talked about the possibility of recurrence in the future. Do you see that in your practice as well? Or do you feel that they kind of go, yeah, I knew that could happen?
I mean, I think we try really hard to make it very clear what the different possibilities of recurrence are. We do a lot of tumor testing in our practice that gives people a very clear sense of what their actual systemic risk is from a recurrence standpoint. But I also love to empower people as part of that living ship that I love so much that you say, Allison, is how can you do something active to try to reduce your risk of recurrence? Because there's a lot we can't control, right?
Yeah.
And so, like you said, you don't want to be having people feel guilty, but exercise is one of my favorite things to talk about with people. Yeah. And I think that really getting people excited about being active, knowing that helps with treatment side effects, knowing that helps psychologically, but also gives you something you can do to feel like you're reducing.
And it's something as simple as just getting moving, isn't it? Because some people can't even comprehend.
Yeah.
What does it mean to exercise? They see someone doing like a HIIT workout, and it's just get walking.
Just walk, just go walk.
Just get walking.
But I also don't think they realize how important, how much they can reduce their risk from it. And so I think that's where, we all do such good counseling with the patients, talking about this is what they can control. You get access to reduce your risk,
Absolutely.
And it can mitigate mitigate some of the things like the side effects, the hot flashes, some of the weight gain, everything like that can be helpful with a little bit of working out.
So if you're a patient, you're thinking about what is life going to look like post breast cancer treatment. In your practices, what does it look like for follow-up? How often are people coming back? Obviously, everyone's screening plan is different, but what do you recommend in terms of how often people should get checked in for how long?
So in the UK, the system is, it's a little bit different, and that's different for the public sector as it is from the private sector. In the private sector, I see people kind of every 6 months and then annually for up to 10 years. In the NHS, however, we've moved to what we call an open access follow-up or survivorship program, where actually people are discharged as soon as they've completed their treatment in a hospital, and they really struggle with it. And there's a lot of pushback from patients because, of course, I was talking about that safety net of having, something there, and they feel quite lost and a bit afraid that no one's keeping an eye on them. Especially as it's difficult to know, how do I now check myself because this breast doesn't feel like it used to, or it's a mastectomy or a reconstruction. What do you think? What do you have in your experience?
So in my experience, I usually see them post-op and then 3 months afterwards, because I typically want to make sure that their oncoplastic and cosmetic outcome after radiation is done looks really good, and that they're doing scar massage, scar taping right up front so we can give them the best aesthetic outcome. And then I see them every 6 months for about 2 years. And then at that point, they can be seen yearly. They can go back to their primary. But I feel like those patients really just want that 1 year appointment with you for that hug, that exam, because you started them on this journey, and it feels like they're part of the family.
Yeah.
So,
No,
how about you, Anne?
No, we do the same. I mean, I think even if it's people, let's say, who are getting screening still with imaging, they still really love to have a breast exam by a breast surgeon. And I totally get that, right? I often say from an anatomic standpoint in terms of how we know the breast, how we know the changes you expect from radiation and surgery, I do think we're the best people to be doing those breast exams. So I try to see our patients once a year too. I think the other thing is, because as surgeons, we do that holistic care, we are thinking about how are they doing on any medications they're taking, what has their screening been like. If they need, let's say they have abnormal imaging and need a biopsy, I want to be the person saying to them, hey, this is something I'm worried about, or don't worry, but let's get the biopsy to make sure. So fortunately, I mean, for me, I think the ability to get to see people and continuing to do that once a year, I love it. It's really rewarding as a provider, for sure.
Yeah, I really struggled with that at first, actually, in the NHS, because I kind of thought it's not an expectation that you set out, you want to be able to offer that. But the good thing is, so the patients can contact a breast nurse specialist directly. They don't have to go back to their primary or their GP. And then they get an appointment to come and see me within 2 weeks. And I say to all of them, I am here. If you need me, I'm here. And so they just come directly back, and I completely agree. Those radiotherapy changes, those kind of parts that they panic about, and actually someone else who hasn't done that procedure on them, you can kind of go, that's kind of completely normal, and straight away they're relieved. They don't want a scan for reassurance. They feel so much better. So, you feel that you've got their back in that way. So
don't be home worrying. That's what I always say to patients, don't be home worrying.
Call.
Just call. Exactly. I would love to see people pop in for a quick exam and just get to tell them that everything's fine. So that's fantastic that you have a system in place so people
I actually use the ultrasound too a lot in my clinic, and I'm sure you guys do as well, but it just shows patients, I feel something here. It may be, fat grafting, or it may be something from their rearrangement. And so I put that on them right away, because I showed them what their cancer looked like in the beginning, and then just say, look, this looks totally different. Pull up their old pictures and say, this is your cancer.
That's a good
this
idea.
is fat necrosis. But let's, get extra imaging if we're worried. But just that moment of them being like, they can just take that breath.
Definitely.
So,
And every so often, I think it's really good to have patients like that to come to see you, because it reminds you to counsel those ones who haven't actually got there yet to go, well, I'm going to do this procedure on you, and actually you might get a few oil cysts and some changes. And even though I think we're all hopefully pretty good at counseling the people pre-op, it just gives a reminder, doesn't it, that you're not always getting people who just you never see again. You need those people to come back so you remember how to counsel the next lot through, to be honest with you. So I think that's really good.
I think lymphedema also can be worked into that time period.
Definitely.
When they come back in to see me, I use a machine where they actually stand on it, a bioimpedance machine where that gives them their actual number. It makes a little graph for them so they can see it's going up a little bit, even though it may be in the green range. If it's getting into yellow, get them in for increased lymphatic massage. But they feel like that appointment to see me includes that, because it's part of the vital signs when they walk in. So it almost gives them like a sense of security when we're dealing with lymphedema, because it's so important. How do you guys
I think that's so good, because actually a lot of the sensation changes, so for example from axillary surgery, they get sensation changes, don't they? So in the first few weeks we say you're going to get this kind of friction burn feeling all the way up to this residual numbness, and I joke, I say, you're going to feel like you've got an orange under your armpit. And then they think it's lymphedema because they think, well, okay, it feels like it's swollen, it's got to be swollen. So to have a way of showing them a graph, I think is brilliant. To use that kind of method?
We've used it before. I mean, I think one of the things maybe we can transition to from that is to talk about lymphedema in general. I was talking with someone recently about, I feel like when we were training and when people used to do more radical lymph node surgery, the fear of lymphedema was bigger. You know, you would know people who went through radical mastectomies and huge ox node dissections, and people knew what lymphedema looked like and were really scared of it. Yeah. Wonderfully now, we don't see a lot of it anymore, which is great, but when it happens, it's still so debilitating. So I know for myself, this move, this shift we see to doing less and less on the axilla is so huge. And one of the things that I've been so excited about is this concept of delayed sentinel lymph node biopsy. So Allison, can you explain, what is that? Who do you talk to about it, and kind of what are you excited about with them?
Yeah, well, I think the concept of saving the nodes needs to be out there for all surgeons, but delayed sentinel node biopsy is specifically in patients who may not need it. Somebody who has DCIS is going in for maybe a level 2 rearrangement of the breast tissue, a mastectomy, and we want to be able to not take their node out. So what we can do is we can actually inject a product, Magtrace, into the breast prior to doing the surgery. Do the surgery, don't take the nodes out, and if there is the invasive cancer found afterwards, go back in and find those lymph nodes. So in doing that, you save so many people unnecessary axillary surgery.
Absolutely.
Yeah, so that along with different techniques can, decrease the amount of problems we have in the axilla, including lymphedema, nerve problems, and all the above. How about you, Anushka? What do you do in your
practice?
practice?
Hope that gets taken up much more widely, because the data coming out shows that 80% of people can be spared having an unnecessary axillary procedure. It's just mind-baffling to think that we're doing unnecessary procedures on people now. We talk every day about how to improve everything that we do for our patients. So, we only want to do things if it's going to have a significant effect on them. But what we do see from doing unnecessary procedures is that significant effect. And now, as I mentioned, the healthcare system in the UK is we don't have that potential of seeing our patients really regularly. How do we know what that impact is really without being able to measure that and understand the effect on their quality of life?
Well, I agree. I think when we think about something like cosmetic outcomes or oncoplastic surgery, and I'll hear surgeons say, oh, it doesn't matter that much to hide the scar or rearrange tissue, the divot isn't really there, the seroma cavity fills in and radiation. But my thought is we know that radiation changes continue for honestly as long as 2 years for some people. And so if you're not seeing people at that time, which a lot of people who aren't doing oncoplastic surgery, they don't see their patients out, they don't know the impact it has. And so I feel like for all of us to get better, to be able to be thinking about those cosmetic outcomes, we have to be seeing people and see the impact. Yeah, so I do think that makes a huge difference. I do love thinking about that concept, though, the thing we hear with patients about they aren't worried about their cosmetic outcomes in many situations. And so how do we help them know that they are going to at some point? And what is that conversation like so that they know that hiding scars and doing oncoplastic surgery matters?
I think patients just don't know. They don't understand what we can do and what has been done in the past and how advanced we are now. So I think that when a surgeon says, my patient just doesn't care, they just want the cancer out. That may be true at that moment, but when they're sitting on the beach with their family, 2-3 years down the road, what do they want to look like? When they look in the mirror and they get dressed every day, do they want to see a reminder of what they went through, or do they want to look like themselves, maybe a heightened version of themselves, and to have hidden scars? Every patient should be offered that. So I think it's our duty to project for them, not just in that moment, because cancer-free is going to happen. I always tell them that we got you, but where do you want to be? And I think you do the same thing, right, Anne?
I do. I mean, as a breast cancer survivor myself, I try not to put my story in too much, because we all know everyone's journey is different, and what I picked or what I went through isn't going to be the same as my patients. But that's one of the few places, if I have someone pushing back and saying, oh no, it's fine, I don't want that, and I tell them, I'm almost 5 years out, and there's so many days I don't even think about having had cancer. If anything, I actually got to look much better than I started. And I do feel like just giving people that, I promise you, you're going to care. There's going to be a time. And right now, everything you think of as cancer, there's going to be a time you won't. And I want you to actually be able to get there. And so that's when I put that in, you can see people's minds like, okay, I guess I'll do this. And I like being able to project forward for them.
Yeah, I think that's so nice. And it really is about making them know that you have their back. We're advocates for them. In fact, when we're having a conversation like this, it gets to me that we have Breast Cancer Awareness Month and we talk about checking yourself, but actually we need to really put something out there to tell patients that we are there to advocate for them and give them a kind of checklist of the things that they should really be going to their clinician with. Because every decision they make in that first consultation is driven by fear. And, you know, I completely understand that. And, you know, empathizing with that, it's kind of, I've got you, I've got your back. Yeah. But what do you want to look like later on? Does it matter? Yes, I can tell you personally it matters. But don't accept anything else, because how many patients say to you, while you're in there, if you think it looks worse, just take everything. Absolutely not. We're going to plan everything. We're going to plan everything before we get there. And just by going, look, it's okay, this is the time to make the decisions. They realize that there isn't that urgency in your eyes that they have in their mind. They sleep on it overnight and go, okay, I can now take that time to make the right decisions. But so many people feel that they have to get pushed into decisions quite quickly and accept inferior outcomes. So I think we need to let patients know that, you know, they need to ask the right questions, and if they're not getting the answers they expect, to ask again, ask someone else.
No, I think it's so important that we think about patients in the future and what they look and feel like. And I think, Anne, you're a big proponent of sensation preservation.
Yeah, no, I appreciate you asking about that, because I do think we can do a really beautiful job with some of our nipple-sparing mastectomy, immediate reconstruction techniques. People can look like themselves, if not better, but it's that loss of feeling. And I know one of my good friends had a mastectomy a few years before I actually got my diagnosis, and she said she would put on a sports bra and didn't feel it was on. I can't imagine what that's got to be like every day, talking about not being able to move past having had cancer. And so we're really excited now that we're seeing this big rise as we've been developing techniques around keeping nerves, reconstructing nerves during mastectomies, that people are really excited about it. And it's starting all over the globe that surgeons are starting to think about the impact of sensation.
Definitely.
Which I think is a huge one. But it is also even things like, we talked about the scarring from a lumpectomy and the impact from a cosmetic standpoint, but what about the functional problem about not closing defects? I mean, what are some of the things you see in people who had non-oncoplastic lumpectomies? It's beyond just how it looks, right?
It's absolutely unbelievable, because I think, you know, part of when you work in a unit where there isn't that consideration of what the breast could be and should be afterwards, people just say, well, it looks fine on the outside, so I'm not going to worry. And then you give the patient radiotherapy, and then you follow them up, and that's when you see that huge impact. And what makes me really sad is actually the patients are still really grateful at the end of it. They go, my cancer's gone, but it's okay. It's not okay, because we know that their survival is directly related to, you know, the satisfaction from their breast cancer surgery. So it's just so important, I think, for surgeons out there to kind of see the range of things. And, you know, we have so much investment over the last couple of decades in oncoplastics and how we can get things looking better. Because breast cancer treatments are unbelievable nowadays, right? Women are doing better than ever before. There's nothing we can't really approach. So because women are doing much better, we've got to let them have that quality of life. And now the next stage with the nerve sensation preservation is just so exciting. I think it's really great to be able to take people forward in that way.
No, I love that. I think that it's so important to patients not only to get a good result the first time, but know that there are options afterwards. So many times patients come in maybe from other facilities with a large discrepancy, and I'm like, let's do reduction lift on this side, a symmetry surgery, maybe a little fat grafting here, but they don't realize, they think their cancer surgery's done. At least in the States, they're still qualified to cover for insurances for symmetry. So they can have things that continue on their journey to make them look what they want to be like. So it's not just that one and done surgery. It really is through their whole livingship period. They can have whatever they need. So I don't know if you have the same experience.
No, it's funny. Well, I was about to say, and I want to, as all of us are, I think, very involved from a social media perspective about education, we all feel really strongly about making sure people know their options. One of the things I personally struggle with is I actually want people to get it right the first time, right? I want them to be armed with those questions. I want them to go see whoever they're seeing and get the full spectrum and range of options. And I love to talk and educate about that. But it's also really hard when people write and say, oh, that's so great you do this, but I wasn't told about it, and now can I come back? And that sort of tension around getting people options, but also not having people feel guilty that they didn't ask those questions. So I'd love to hear, again, as both of you as kind of, I think of as experts in the breast cancer education space, you know, what do you do to not have people who've already had things feel guilty, but still get the right information to people who are in their process?
Gosh, I think it's just so hard. I think, so part of what I would do in my practice is make sure that I write my letters to the patient. A lot of people are still in the phase of kind of writing to the primary physician. And so I saw this lady today, but I write to the patient as if it's a record of our discussion, basically. And I say, please scribble on it, write back if there's something I've not got. I want this to be your crib sheet for everything, so that you have an idea. if I'm seeing a patient who's already had surgery with somebody else and they've come because they're not happy with the aesthetic outcome and wonder what their options are, again, it's then managing that expectation, because look, I can get things better than what they are now, or can I actually not do that? But it's okay, these things happen. And again, it's not having that guilt about not asking those questions up front. A lot of things out of people's control, aren't they? They have to just go with the flow, and they describe this riding the wave of treatment as they go along, and you don't really get time to stop and ask questions afterwards. So getting that information up front is so important. Having a nurse specialist there, I think, to advocate for that patient as well. And written information out on the web, putting it out there on social media just as much as possible. What do you think?
No, I agree. I think that knowledge is power when it comes to that patient experience. And so I give them everything, but that first visit is a lot for them. And so I find that I write it all down, right? I write everything down, all of your options, what you can look like. Then I have them back for that second visit, and that's really the surgery planning visit. So they've had time to absorb their diagnosis, what stage they are, what the tumor receptors are, what the options are, and then I leave them with a bunch of videos, literature, nurse navigator, all the above. When they come back in, that's the moment where they look in the mirror, I draw on them, we start talking about that, and so those expectations are now able to sink in. I found in the beginning I started doing it all at once and it was too overwhelming.
Agreed.
And so splitting it up into 2 visits, it just allows them to actually make the right choice for themselves. So I think when we look about how to improve post-operative care for patients, or what one tip of advice, is there one thing that you would give to them, Anushka, to tell?
Gosh, God, I wish there was one thing I could tell them. I could write a book on the things I would give them. I think some information that's really lacking out there, and I feel quite hungry to learn better, is that nutritional advice. Because, we talk about that whole holistic package, and we said about what are my modifiable risk factors? What control can I take over my life right now? And people think they have to start changing their diet radically and not ever drinking coffee and not drinking wine. But I think so the main thing is about, again, it's everything in moderation, but to give them that real advice would be so helpful. And then the other key thing is dealing with that being put into early menopause, or the hormone depletion that women have. There's a huge movement now. Women are feeling so empowered to kind of go, hey, what are my options here? My body is completely changing, and it's happened maybe a decade before I was expecting it to. What do you say to your patients who ask about those options?
I mean, I think so much of this, because like you mentioned, we treat breast cancer so well nowadays, we really do have to truly think about survivorship, and that means the living ship. It means what does your quality of life look like? So I'll have very open discussions with patients about what are the side effects they're having and how is it impacting their life. And a lot of times we aren't doing a good job, honestly, as providers, talking about things like body image and sexuality and what all of this has. And if we don't ask the questions, people often won't bring it up. But impact on sexual health is a huge one that I think there's actually a lot we can do that's very safe that people just don't know about. So that's one I try to work on a lot. And then we also weigh risks and benefits. If I have someone who has, let's say, has a BRCA mutation, has had a mastectomy and had her ovaries out and wants to go on hormone replacement, see, that's fine. Your amount of minimal breast tissue, we know that's a safe thing to do, and so helping them work through that, I'm giving you permission, your breast cancer risk is really low. It really means a lot to people, because even if they see the data, I think it still means so much to hear from us. We know you, we know your family history, we know where you are, and we think this is safe and going to change your quality of life.
I love that. What I'm hearing is individualized care for each patient. That's really what we're giving them into that period when they're cancer-free, that they still need that individualized care. Not every single person needs to go on anti-hormone therapy. And I think there is a nice balance that we can create out there to give women their lives back without causing lots of significant problems. So I love that.
And I think what I see as a real problem is compliance with medication taking. And really when you bottle it down and ask women why they're not taking the medication, is because they didn't feel listened to in the first place. They were telling people I was having these symptoms, and nobody gave them any other options, and they just felt a bit helpless. So you'd rather know that your patient's able to speak to you openly about things. I always say we have uncomfortable conversations every day. Why is talking about sexuality anything different? Talking about nipple sensation, those kind of things. So I think it's great that, we want to bring those conversations up. We just want that to be a much broader conversation with everyone else as well.
I was going to add one thing else when we ask about tips. One of the things I'm pretty surprised by is people who have had surgery, especially lymph node surgery or radiation, and no one told them about physical therapy.
I know.
And I know in some places it's an issue in terms of having access, and I've heard that, but honestly, in my mind, we send every single person who has anything other than a very small lumpectomy or excisional biopsy to physical therapy. And we love it. I think it helps a ton with postoperative swelling. It helps with scar management. It helps with tightness after radiation. I mean, it's huge, minimizing lymphedema risk. And so I think that's when, again, that I would love to get out the message to patients and providers about how important that is. It's also a really great Kickstarter for getting on an exercise program.
Yeah.
And so a lot of times if I have patients of mine who are very active, they may be nervous about getting back in, and we know that's going to help them with their recovery. It's going to help minimize their chance of recurrence. So I love working with a physical therapist in that setting to get people kind of back to themselves again.
I agree, and I think patients sometimes don't realize that it's okay to do that physical therapy.
Yeah,
They're like, I just had surgery, I'm not supposed to move, I can't go above 90, And it's like, no, yes you can, we want that. It can be done safely, and if it's under the guidance of a physical therapist, I feel like that gives them that safe zone to get back to their life.
Wouldn't it be amazing to have a program for people? Because actually with lymphedema, once it's developed, it's really hard to deal with, right? Even with the advancements that we have with surgery, it's something that can be so debilitating, but the only thing that we know can really help is pre-operative exercise. So actually you're talking about a post-operative therapy program. Wouldn't it be amazing at the point of diagnosis to go, okay, you may never have really considered exercise before, but these are small things that you can do now before we actually get to the operating room. And when you're done, here's how you continue. And it's just a great way to kind of take them all in, envelop them in that kind of care from the beginning to the end. I think that's a good idea.
No, I love that. I think that adding that, I tell patients, you've got a lot of information today. You're going to run a marathon. This is definitely not a sprint. You've done no training for this type of cancer care, but each day I want you to do 1 hour a day off of a list of things that make you feel like yourself. To remind yourself each day to reset yourself. Don't think about cancer, don't Google cancer. Sit in that moment and say, what makes me feel like myself? Adding exercise into that is such a great idea to tell patients, and I challenge you even further after your 1 hour a day, do 30 minutes of exercise now to clear your mind before you get back into that, okay, do I have chemo tomorrow? What all these different things that a cancer patient goes through. So just that reset, adding in that.
So nice,
It's
isn't
really
it?
great.
I'm stealing that one.
I'm definitely stealing that one.